Welcome, everyone. I'm honored today to welcome Dr. Jonathan Samuels, who's an associate professor of medicine at NYU Langone Health, where he also serves as associate director of the clinical initiatives in the Division of Rheumatology. He has been using musculoskeletal ultrasound in his clinical practice and research since 2008, and is the division's director of MSK Ultrasound. He is a mentor and board member of the Ultrasound School of North American Rheumatologists, an online training program for rheumatologists to learn ultrasound techniques, and teaches ultrasound at various weekend courses designed for rheumatologists. His ultrasound-based research has focused on applications and questions in osteoarthritis and gout, while most of his other investigative efforts are centered on clinical research in osteoarthritis.
Thank you so much for the invitation. I appreciate speaking to a group of musculoskeletal radiologists. I'm at NYU, where we have a wonderful group of MSK radiologists, and it's been really such a help over the last 15 years to always have such a good relationship with them. So I know how important it can be. I do want to say throughout the talk, if there are questions, if there's a mechanism, I'm happy to be interrupted. We have that culture at NYU. We like to interact, so feel free to stop me as we go through. So I have no disclosures, but just want to say that we really respect the radiology expertise, and even though we do a lot of ultrasound, or I do a lot of ultrasound and rheumatology, really rely a lot on our radiologists to help, and I know it's a really good partnership that we have. So some key references. I'll start out with a little vignette just to get the juices flowing here, and tell you how it may play into our day-to-day, and then we'll go into more of the didactics here. So 37-year-old woman with months of wrist pain, tenderness, MCP, PIP, discomfort symmetrically, some swelling. The blood tests really aren't that helpful, the serologies we normally send. X-rays are negative, and she's not an MRI candidate. She's not going to go in with the claustrophobia, and it would take a while. So sitting there in the office, how could we figure out what's going on with her? You may have some ideas. So what's the differential diagnosis? What further imaging? Of course, the answer, because we're here to talk about ultrasound, is to use that modality. But the differential is going to be thinking about rheumatoid arthritis and lupus and other inflammatory arthritis syndromes, even with a borderline rheumatoid test. So what do we do at that time after someone's coming in with these months of symptoms? At the top is just a quick image, just a normal wrist, where you see where the probe would be placed at the top, and see the radius, the lunate, the capitate, the extensor tendon coming across. And this is a healthy control where there's no synovitis, normal joint spaces here. But in this patient, you can see in the dorsal longitudinal view, there's plenty of synovitis and interruption here, maybe even some erosions. There's some possible fluid, and then you turn on the Doppler, and the patient will have some activity and go in transverse, and you'll see a tenosynovitis around the tendon. And we'll get to how you interpret these images, just giving you a little taste of it. But this is just an example that we use that it can really be helpful to diagnose inflammatory synovitis and tenosynovitis when the lab tests are not that revealing, and you're really equivocal, want to show the patient what might be happening right then and there in the office, and they'll be more apt to follow your lead in terms of taking medication. So what are the objectives overall of our talk here? I'd like to discuss the emerging role of ultrasound in the rheumatology clinic and on the hospital wards, describe the general sonographic characteristics as we see them as rheumatologists. What are the important things that we look for when we're using it? And then also describe, obviously, the pathology. What do we see in terms of indications for use of ultrasound? When are we using it? And what are we looking for in certain diseases? So just to water it down here, just to outline, these are the three topics. We'll start out with some background and basics. And the background is important in terms of where we're coming in. Now, at NYU, I'm the only rheumatologist in the faculty who really does it day to day. Some people have dabbled, they do it some time to time, but there's a big learning curve, as you know. We don't do a residency or fellowship, so learning it on our own on the side takes time. So most rheumatologists are not using it as a whole, but most institutions have someone. But who's using it besides us? So obviously, you all do it in radiology, but physiatrists, orthopods, pain management, sports medicine, they're all using on the ultrasound, largely more so the other specialties, the non-radiology specialties, on soft tissue injury diagnosis, treatment guidance. As rheumatologists, we're using it for that, but also for inflammatory and autoimmune disease diagnosis. So we really see it as an extension of our physical exam if we learn the technique. I think of it as my stethoscope. I probably use it more than my stethoscope, although I do listen to patients' lungs and hearts with the stethoscope for many of our autoimmune syndromes. But this is really a very helpful tool. Just to tell you briefly how it got to us in rheumatology, just a quick history from the 70s going on. It really started out in Europe, um, looking first at Baker's cysts versus DVTs, then demonstrating some Tenosynovitis. In the 80s, the Germans really became much more apt to use it. In the 90s, it became integral part of training in Italy and Spain. I actually, in the late 90s, spent time in Scotland for a brief month, just a rotation, and they were using ultrasound in the rheumatology clinic. I thought that was interesting. Of course, the rheumatologist who was doing it there, I then met 15 years later when I started getting into it. So it was a nice um, piece of continuity. By the 2000s, it was really being introduced in the United States and other places, weekend-long courses just for rheumatologists, how to learn how to do it. So what did I do in 2007, 2008 when I started getting involved? Because I came to NYU and it was one of the things I was asked to take a look at, and I took it as one of my interests. So I actually looked at all the rheumatologists in the country, and we did a survey of all fellows, all rheumatologists, all program directors, and we got a decent response. And of course, there's a bias in who would have responded, but what we found in terms of the people who responded to our survey, that almost a quarter of members were using ultrasound, and another quarter were referring patients to you all. And what do we actually find in terms of people's thoughts? Overall, it really wasn't that commonly used, still about a quarter or less in terms of whether, regardless of level of training and how long the doctors have been out, geographics. But most felt at that time, 2008, that really it's where the future is. We should be using it. It should become more of a standard tool. And in terms of who's really attended workshops at that time, really most of the young pups were the ones doing it. The members who were out 15 years or more, which is where I am now, not that many of them were interested or involved relatively. But of course, this is really only a subset, as I said, of the people who answered the survey. So maybe a meaningful trend at that time. But after that, in the last decade, the ACR, American College of Rheumatology, has started running courses annually, and we teach at those when we can actually get there in person before COVID. And then by 2013, the American College of Rheumatology started its certification exam to show that you had gone through. You have to have done a certain number of courses and scans to even be eligible to take the exam. But if you pass that and you've done all the other requirements, you get the RHMSUS notation that some people put at the end of their names. I feel a little funny putting that right after MD, but that's really how we're self-certifying within rheumatology. And now most rheumatology curricula have it. There's also something called US Sonar, which is an online course with mid-year meetings, and the fellows and attendings, they upload images, and we really see how well they're doing and try to get them up to speed. At the end of the year, there's an exam. And then there's a task force that's really looking at, around the world, looking at how rheumatology can use ultrasound for research and doing better. And so there was a paper that we published just last year in 2020, and now compared to what I had published in 2008, now we have 94% of programs are teaching ultrasound, and 41 have a strict curriculum for the fellowship program. So this is really the here and now for young folks coming out into rheumatology. And we have our book that we published in 2016, most of the American rheumatologists who are scanning. We put together a good review book, and second edition's coming out now. In addition to the machines, you use these huge, amazing machines. I see what our radiologists use, and we've been using the portable versions that can go from room to room. But now in the wards, it's a lot easier because I'm sure you've heard of the Butterfly, and it hooks up to your smartphone. We are getting them. We haven't started using them yet, but it's really going to make it much easier for a fellow or a clinician on the ward to use that, scan something, send it to me wherever I am, since I'm the one who does most of the interpretation, and say, well, we need to go to radiology and get better assistance, or we can make some clinical decisions. We still really rely on your expertise, and appreciate that all the time. So I won't spend a lot of time on all the basics of scanning, because I know many of you who are tuned in here are scanning yourself, so you don't need to be taught that. But I just want to tell you briefly a few things that that the non-radiologists, the rheumatologists who we train, what we definitely need to know to understand the images and to get started, at least before delving in further with long weekend courses. Obviously, we talk about that the echogenicity, that the denser, more reflective of sound is more echogenic or white. Those are the bones, the tendons, the ligaments, sometimes the calcium. The middle is the hypoechoic or isoechoic with synovium, nerves, muscle, fat, fiber, cartilage, and the black is really anechoic, the fluid or the water-filled hyaline cartilage. We also make sure that from a rheumatology standpoint, we're doing it on the patient in the clinical setting. We like to have standard ways of looking at images, so we can always review them later and share amongst each other. Obviously, the no sound waves penetrate the bony cortex, so you're going from top to bottom, from skin down to the bony cortex, and that's where it ends. The left side of the screen is always supposed to be proximal, the right side is distal. Similarly, the left side, we always, for convention, have it as medial or ulnar, and the right side is lateral or radial, and anterior and posterior. And then we can interpret our images years down the line or with each other. For power Doppler, you may be a little more complex and sophisticated, but for us, in terms of looking at our synovitis, we really try to have a 0 to 3 semi-quantitative scale in terms of looking at hyperemia at the microvascular level. Do they have active synovitis in patients? Are they getting better as we give them the immunosuppressive treatment? Of course, there is the intermachine variability and a lot of parameters for us to adjust, but we try to do our best in evaluating these patients. If there's a mild vessel activity, we call it 1+. If it's less than 50%, 2+. If it's more than 50%, we call that the 3+ semi-quantitative scaling. I'm not going to go into the physics, the probe positioning, how you hold the probe and maneuver it, the optimization on the machines themselves, and also the whole point of confirming pathology in 2 views. You all know that. These are things we really hammer home as we work with the fellows and the rheumatologists as trying to show them how it can be useful. So in terms of sonoanatomy, this all may be standard and basic to you too, but just to quickly review what we discuss with the rheumatologists. We do really want to make sure they master everything. We really learn all these different tissue types in normal, healthy patients. We tell them to practice at home, bring the machine home if they can, or do it, on your family members, your dog. You can't practice on your cat because that would be a CAT scan. That's my one radiology joke today. That's it, I promise. Okay. So what are the different tissue types? Obviously, bone is so important for getting landmarks, but it's the hyperechoic, usually smooth contour, posterior acoustic shadowing. So this is just one example. Articular hyaline cartilage is always anechoic, not compressible, right over the bone. You see these areas over humerus, over the femoral condyles. Skin is really the most superficial layer. Should just be 1 to 2 millimeters thick, and we really tell all of our trainees that to use as much gel as possible and not have any airspace, and gel is almost free, so use as much as you can, never be shy. The fat is below the skin with a more marbled appearance with the hyperechoic septa. And then we get to the muscles, 2 views, longitudinal and the transverse views. As a longitudinal view, you're going to see more of a pennate structure, and the transverse is going to look more like a slab of meat with the hyperechoic rim and bundles within a hypoechoic structure. Nerves, more longitudinally viewed, are going to be have a hyperechoic epineurium surrounding the relatively hypoechoic nerve fibers. You can see blood sitting above the tendons. And then transversely, you're looking for that honeycomb pattern, or coarser than the tendons that are below it, less anisotropic than the tendons as well. We'll discuss anisotropy in a few minutes. Tendons and ligaments themselves, fibrillar fine structure, homogeneous pattern. You can see them coming across the joint space, and patients, very, very easy to have the patients move their digits and see the tendons move over the joint space. Also rocking the probe can adjust for the anisotropy that I'll discuss in a minute, but just in terms of the angle hitting it straight on, you don't get the perfect structure in view if you're really not parallel to what's perpendicular to the actual tendon. And then the orthogonal plane question, you can see the same tendon in two views. As with most structures, longitudinal and transversely. You just turn the probe around so we can see this flexor tendon very nicely. Fluid, just to mention, the anechoic, as I said before, it can be articular, intra-articular, it can be bursal, it can be a cyst, and the fluid is generally compressible and displaceable without Doppler signal, and the vessels and the veins are compressible, so we try to make sure that we don't press too hard down and try to float the probe on plenty of gel. The arteries will be pulsating, and you can see a Doppler signal if you turn it on. Few artifacts to mention before we get into all of our pathology. These are the big three that we focus on. The anisotropy is this effect that if you don't hit something exactly perpendicular at 90 degrees, the waves won't bounce back and won't have as bright as a signal as you would otherwise. So here, it's a nice view, but if you have a curved structure, some of those sound waves aren't going to bounce back, so you get a little bit less bright, as in we just shown that that quadricep tendon before. So we try to maneuver the probe to make sure the pathology is not artifact, and those are the maneuvers that I'm sure you are more comfortable with. We just discussed it, but just one example is if we're looking at a carpal tunnel, you see all the flexor tendons in view, and then the nerve will look should be there as well. But the rocking of this probe, you see how now the probe is at an angle, and so those sound waves aren't going to come right back up. It's very important for us in rheumatology to make sure we're not misdiagnosing something that's really artifact. So now those tendons have really come out of view. So if you just start with the angled probe on the right, you're not going to see the tendons. You think maybe there's a fluid collection, but really it's just a matter of anisotropy. And really this is helpful also to distinguish between the tissue types, because the tendons will be anisotropic, but muscles, nerves, not as much, and the fat and the fluid won't have it at all. So you can really distinguish between artifact and real abnormality. The second and third, acoustic shadowing. The sound is blocked distal to a hyperechoic structure, and so the sound wave doesn't reach the deeper structures. So here, you think of this osteophyte that you can see with the yellow arrow, or orange arrow, is possibly hiding an erosion. You don't know, but this is really, you want to see the full bony cortex, but you really can't tell because that is there's shadowing behind it. And also enhancement, if you have a fluid collection, it may increase the signal below. And here you might think, oh, there's a hyperechoic structure underneath this anechoic cyst, but really that's just really making it brighter, and it's just an artifact. All right, any questions before we move on to the big part of the show? Sonopathology and utility in rheumatic diseases. Okay. So it's really helpful to look for so many different types of pathology. Just going through them, listing them: erosions, synovitis, effusions, tenosynovitis, enthesopathy, all the productive changes in cysts. And we'll go through them one by one now. But where are these popping up? In many of our diseases: rheumatoid arthritis, the spondyloarthropathies, osteoarthritis, crystal disease, lupus, nerve entrapment syndrome is helpful, and then a lot of the soft tissue disease. I'm not going to spend time talking about polymyalgia rheumatica, temporal arteritis, Sjogren's syndrome, or scleroderma, but these are all fields now, subdisciplines within rheumatology, where ultrasound is becoming very important. It's less musculoskeletal, but it is now something that a lot of rheumatologists are able to help diagnose and follow with ultrasound. So let's go through some definitions of pathology, and these are not new definitions. They've been around and it's been sustained over the last 15 years. A bone erosion, by our key definitions that we use from this original article, is an intra-articular discontinuity of the bone surface that's visible in two perpendicular planes. Of course, gout is a little different. Sometimes you don't see them in the intra-articular area. But this is where we see most of the bone erosions, and the defect should generally be more than 1 millimeters. Sometimes you need to look for even deeper 2 millimeter defects or erosions. And sometimes we do see some of them on healthy individuals, so we have to look at the clinical story along with it. So here's a classic image from rheumatoid arthritis literature, looking at longitudinal and transverse view of an erosion in a metacarpal. And you can see the metacarpal bone. It's not great resolution here. Our images are much better 15, 20 years later. But you can see the deep, with the red arrow, the erosion down into the cortex. And on the right side of the screen, you can see the schematic, what you should be looking for. And so this is just a way to help diagnose an erosive process. This doesn't mean there's acute inflammation, because once the erosion is there, it's usually yours to keep. But at least you see that there is a damage. Another great article looked at X-ray versus MRI versus ultrasound in a patient with significant RA erosions, and you can see there's nothing on the X-ray. The MRIs on the left have the arrows pointing to where a couple of the erosions are, and those corresponded to erosions seen on the ultrasound in the metacarpal bone as well. So it just shows you can see the same things in both ultrasound and MRI. Erosions here, just more examples, seeing in the wrist, and a couple of different areas near the ulnar styloid, and then below on the medial epicondyle. So plenty of areas to see erosions. And so looking at this from a larger standpoint, how much better is ultrasound than plain X-rays? And of course, early on, you're not going to see the erosions that often. It takes a while for them to appear on radiographs. And here it seemed to be a 6-fold difference in early RA. And for late RA, it's not quite as stark, maybe 4-fold, but it's much better to find those erosions, easier to find the erosions on the ultrasound. Synovial hypertrophy, next topic, is something that happens well before you have erosions, and that's defined as abnormal hypoechoic intra-articular tissue that is non-displaceable, poorly compressible, may exhibit Doppler signals. So see here, so you're seeing a lot of this extra tissue. And of course, you can put the Doppler signal on and see this light up in this dorsal longitudinal wrist. It's just a patient of mine who had active synovitis coming in, needing some change in treatment. And as it turns out, this patient also had erosions in addition to the synovitis. This is someone who had long-standing disease that was not well controlled. Synovitis often, as I said, is visible before any erosion formation. So here's an example of the bones looking fine, but there's plenty of synovitis and inflammation going on. And if this goes unchecked for a long time, then you'll start to see the erosions. Effusions, fluid, very important to find, and probably the most important thing we can do in the clinic day to day, because look, there are patients who look like the ones on the left-hand side. Of course, that bottom knee has a large effusion. We can tap that, aspirate it with our eyes closed. On the right side, is someone has knee pain, you're not going to be looking for fluid or trying to drain them, aspirate any fluid, because you can see the patella quite clearly. There's very unlikely to have any fluid there. But most of the patients are not going to be there. They're going to be right in the middle. Who knows if there's fluid there? You can maneuver, you can palpate, you just don't know. And this is so helpful, because in 2 seconds, it's not a billing issue. I just put the probe on and really have an idea, is there fluid there to aspirate? If I'm going to do a procedure, I can always, and it needs to be guided, I can always make it a more formal study. So effusions are inflammatory or non-inflammatory. OA does not necessarily have an inflammatory component all the time, but there could be fluid there. And it's anechoic or hypoechoic intra-articular material that is displaceable, is compressible, and does not exhibit Doppler signal. So here's an example of a regular knee, as you can see, with patella, the quadriceps, the femur there. There's no effusion there. But comparing it to an effusion, you have your quadriceps up here, you have the femur down below, blocked by the word here. You have a suprapatellar longitudinal view of an effusion. And you can turn the probe around 90 degrees and have your transverse view of the same effusion. So just to review and compare, we think very frequently about, is there hypertrophy or effusion or both? And here again is a comparator, hypoechoic versus anechoic, not compressible, displaceable versus is displaceable, compressible, and may exhibit Doppler signal and does not have Doppler signal. And you go back and forth between these two. And these are principles that we rely on daily. I should say though, sometimes you're going to have both. And here again on the left-hand side is our normal healthy knee. Well, here's an example of a knee with some pretty significant osteoarthritis, as it turns out, a fusion, and has a lot of synovitis. You can have synovitis even in osteoarthritis, as we found. It's not just an inflammatory rheumatoid arthritis picture. The synovial tissue is different than it would be in RA if you look at it under the microscope, but under the ultrasound, it's hard to distinguish, and we do see that oftentimes. And why is that important? Why should we be caring if we are in the clinic, all of a sudden, do we find any synovitis? Do we find effusions? There are a number of reasons. In rheumatoid patients, those with baseline wrist ultrasound evidence of synovitis are twice as likely to develop erosions at 12 months. We want to treat them more aggressively. We may go faster to an anti-TNF biologic molecule than just using methotrexate. Another study found that Doppler signal is also important, a predictor who's going to flare in their regimen. If they're stable in their regimen, but they have active Doppler signal at baseline, they may be more likely to flare in 1 year. It may be more helpful even than the clinical exam, lab tests, or other imaging. And then in terms of the knee, in an osteoarthritis knee, who cares if they have a little bit of fluid there? It doesn't really bother them. Well, the studies have shown that if you have a large effusion, more than 4 millimeters in size, we're 2.5 times as likely to need a knee replacement within 4 years. And that's over 600 patients, and by a very respected investigator. And, even if it's not quite as grand, the point is if you have fluid there, patients need to know that do everything you can to minimize their risk of progression. Lose weight, don't run, don't have as much impact exercise. These are things that we can tell with ultrasound. Tenosynovitis, hypoechoic or anechoic thickened tissue with or without fluid within the tendon sheath, possibly with some synovitis nearby. These patients may exhibit some Doppler signal. You can see this one in 2 perpendicular planes. You can see longitudinal, all the fluid surrounding the tendon with a lot of Doppler signal. You go transversely, you can see the fluid around there as well. So these are very helpful images to us. You can see that in the wrist, just another example. And one of the European rheumatology sonographers who wrote the important basic textbook that we use, while ultrasound and MRI are equally sensitive in detecting synovitis, ultrasound is more sensitive in detecting tenosynovitis in RA patients. So it's a very important tool for us. In terms of rheumatoid arthritis, I don't know what you do in your scanning patients who may have autoimmune disease or rheumatoid, what you report. But for us, we realize we can't scan everything. We'd be there all day. We can't see the next patient in 15, 20 minutes. There have been many rounds of what's important for research studies, for practice, 38 joints, 28, 20. There's one scale, this is now a decade old, the German ultrasound 7 score, looking at the wrist, a couple of the MCPs and PIPs and MTPs, and looking for erosions, tenosynovitis, and synovitis, and try to get a score. Look, this is the least that we use in research studies, but for clinical practice, I still think it's too difficult to really incorporate if you're in a busy practice to do too many joints. So I think we have to be more focused. And then does this help us change our therapy? Once someone's on TNF or biologic therapy, are there clinical parameters? This is 5 years ago. The verdict is still out, but hopefully ultrasound will eventually be able to help us decide who we might be able to try to give a drug holiday or reduce the amount of medication we're giving patients if they're doing well. Enthesitis is abnormally hypoechoic loss of architecture and or thickened tendons or ligaments as bony attachment seen in 2 perpendicular planes. That's the definition. We know that these may contain calcifications with hyperechoic foci. They may exhibit Doppler signal, and they may develop some bony changes. So what does it look like? So for the spondies, we look, here's a normal calcaneus, normal Achilles tendon coming in, but what else do we see? So we can find, number 1, find the cortical defect, the erosion. Number 2, find some calcifications high up, find some thickening of the tendon, and maybe less echogenicity of the tendon, and finally some Doppler signal. So these are many key findings in enthesitis. These spondies also will give us some peripheral synovitis and erosions, similar to rheumatoid arthritis. Patients will also have dactylitis and periostitis, which we can try to help find with ultrasound. Tendinosis, thickening by measurement and bony contour, is a loss of fibrillar pattern and the hypoechogenicity, like we mentioned for the Achilles tendon before. So a lot of ways we can find tendon disease. But then this big picture of productive change and deposition, osteoarthritis, crystal disease, we'll talk about these. What are the key points? So just as a teaser here, for hip osteoarthritis, very common. And yes, you can get all your x-rays and find, get more detailed images, but right then and there, if someone comes in with hip pain, I can tell them right away if they have hip osteoarthritis. I can put that probe on, the left side is normal, nice acetabulum, femoral head, femoral neck. But you go here, acetabulum has these elevations, the femoral head, acetabulum and the femoral head have these osteophytes popping up. Here, at the end of the acetabulum, and farther in the acetabulum, you have osteophytes. That's causing a lot of pain. You can't see all the cartilage there. You can't see as much as you would in an x-ray, but even before they have to go forward to do all those radiologic studies in the office, I could put the probe on and give them some helpful information. And you can also look for synovitis in the hips in these areas. Why is that important? Because those patients who have synovitis may be more likely to respond to steroid injections. And this was found at 4 and 8 weeks. So you may be more likely to try to use the ultrasound to give an injection, which I'll describe here in a little bit. Excuse me. So osteophytes, again, thought to be cortical elevations, superficial to the normal bone surfaces. So here is a medial knee joint. Here's a healthy, nice femur and tibia coming together, meniscus in the middle. But at this joint margin, you can see on the right, here's the femur, and all of a sudden there's this elevation. So it's an osteophyte. It's a bony elevation. Bone spur, as the patients will ask you, what are you showing me? Both in the femur and the tibia, sometimes only on one. You can see it in different orthogonal planes too. If you go transversely, you can see it different areas. So looking for these osteophytes can be very helpful early on. Also looking at the cartilage damage. So if you have them flex their knee fully, you can bring the femoral articular cartilage into full view, as we have here. And the red stripe is where the probe would be on the top. You can see a nice healthy femoral articular cartilage on top of the bone. This is water filled. That's why it's so dark. And it goes from condyle to condyle of the femur. However, we can see that that's often not the case. They can be worn on one side. They can be narrowed and really fuzzy. And the cartilage is not there as would be in a healthy patient. So then we look at the posterior knee. We can see a lot. So here's an example of an obese woman with knee osteoarthritis that's done well for a period of time, but no longer responded to NSAIDs. Physical therapy is not helping anymore. Still having a lot of pain after the anterior knee was aspirated, just took out a good amount of fluid. The fluid was bland. It was not inflamed. 850 white blood cells is osteoarthritis. But now the patient says they have a lot of posterior knee pain. So as with the other vignette, I'll say, what is our differential diagnosis? Is further imaging indicated beyond the x-ray, and how can we treat the pain? So the differential diagnosis, it could just be osteoarthritis, but if there's fluid back there, you think there may be a popliteal cyst, which we see in RA, OA, everywhere. And of course, we're here in an ultrasound talk, so I'm going to tell you, you can use the ultrasound to find it, and I'll show you how. And how can we treat this continued pain now? And we can actually drain that fluid pretty easily with the ultrasound. No rheumatologist should drain a popliteal cyst without ultrasound. You don't want to hit the vessels. You want to make sure you're safe. So in this cyst, you see in the transverse axis, you see this C-shape in between the medial head of the gastroc and the semimembranosus farther up. Okay, and then turn the probe around longitudinally, and we'll see this popliteal cyst in full view. And I'll show you in a few minutes how we would go about draining that from our perspective in the rheumatology clinic without any hesitation. So all this I've talked to you about osteoarthritis, these different findings I think are very important. In osteoarthritis, the holy grail is what is going to be a disease modifying treatment. We don't know we have nothing to give them other than pain relief. Even some of these nerve growth inhibitors, all these other treatments are just aimed at pain. We have nothing like we do in rheumatoid arthritis or lupus or psoriatic arthritis where we have these biologics. So we have to find a way to treat them. The problem is, for the studies, you need to be able to find a treatment that's going to show effect. And osteoarthritis is often so slowly progressing, they would take years to show. So our goal is to really find a way to pluck out the patients who are fast progressors. About 30% of patients with knee osteoarthritis progress at a much higher rate. And we've shown this in many studies at NYU and other groups. And we've looked for ways to identify. So I'll go through some of them, but I did this project based on our chair's NIH-funded project to look for biomarkers in the blood of who would be the fast progressors, and looking at patients at baseline in 24 months in terms of their x-rays, plucked out the patients who had fast progression over that time, then going back to the blood biomarkers and MRIs. But I did ultrasound as well. So if we can do that, if we can find the fast progressor subset, we can enrich our studies future studies looking at drugs that might help osteoarthritis. So in this cohort I mentioned, X-ray progression 24 months, looking at these different types. We published papers looking at, our group has, looking at different cytokines that may really tell you who is progressing faster, but you really can't always rely on those alone, and it hasn't been helpful enough. So while looking at the ultrasound, I said, let's look at these findings that you really can't see in the X-ray. Let's see what happens at baseline. What do they have at baseline of their on their ultrasound of the knee, and what happens to those groups? So I took the two groups, the non-progressors in this cohort. 144 patients did not move their KL grade at all over 2 years, and the progressors, there were 28 out of the 170 or so. The progressors, fast progressors, I looked at them separately. And if you look down the different rows here, the effusions were significantly higher in the patients who progressed. The articular cartilage wear was approaching significance. The osteophyte size, we graded them semi-quantitatively, 0 to 3. The score of their osteophyte size was significantly greater in the progressors. And then the popliteal cyst size, we also did a semi-quantitative, was much greater. And the composite score, putting all these four components together, was significant. So then we also adjusted for confounding variables. And while some of the individual components weren't quite there, they're still fairly significant in terms of 0.05. Overall, popliteal cyst size was still quite significant, and composite score was definitely significant. So I just think that this is another way. We're still trying to get this published. We presented it at our annual conference, but it may be another helpful tool to determine who should we pluck out of patients or trying to enroll in studies, and who should we use these new disease modifying candidates for going to the future. So radiology and ultrasound may be very helpful. I'll shift gears now to gout and crystal disease, where we have ultrasound evidence of many features of gout. Go through. In terms of looking for these erosions, this is a study now more than a decade old, and this is the first one to show that ultrasound can detect more erosions at the MTP joint than X-ray, and also show that you can identify subclinical disease, people who have high uric acid levels, not necessarily gouty attacks, but have erosions already. And so really, should we be even treating them earlier on? You know, can we prevent further erosions by identifying gout patients before they have severe gout attacks? We looked at this in our group as well. This is, you can find tophi in bursi and other areas, more heterogeneous appearance. You can find tophi in MTPs of gout patients. And we looked ourselves at this question of asymptomatic hyperuricemia before they have actual clinical gout attacks. And we found patients who had plenty of gouty tophi appearing, even though they hadn't had attacks. And maybe these are patients we want to treat earlier as well. The double contour sign is kind of the catchphrase in terms of using ultrasound to diagnose gout. You find this hyperechoic layer of uric acid deposition on top of the hyaline cartilage. So you can find this on two views, but we find this also in the knee, a hyperechoic layer on top of the femoral articular cartilage. So here again, is this another place we want to consider treating patients earlier to prevent further damage and erosions. Chondrocalcinosis, CPPD, also used quite frequently. Instead of the double contour sign, we find a layer on top of the cartilage. We find these calcifications right in the middle of the cartilage. So when we think of looking at knee x-rays, and you think of the meniscus showing that calcification for CPPD or pseudogout or chondrocalcinosis, here we can find it in the ultrasound, not just in the meniscus, which we can view parts of it. We can look at that femoral articular cartilage and see these lesions right within the fibrocartilage. And some people call it the pseudo double contour sign, in playing off of the double contour sign of gout. But here's a distinct presentation of this. And we find this in the wrist of the TFCC. We see it in the cartilage in the knee menisci and elsewhere too. And putting it all together, this classic image is always very helpful for us in teaching purposes. The control or above in terms of femoral articular cartilage. You have your bone, and then you have just a nice normal layer over the top. But you get to gout, you have the double contour sign with two bright layers, and then you have this stippled kind of middle of the road effect where you're seeing in pseudogout coming through the cartilage. Just quickly, bursae were very helpful for us in the clinic. We see plenty of bursitis and fluid to be drained or injected. Um, Subdeltoid bursitis, here's a normal on the left, and the right you see this large collection. So this is very common, one of many examples, not to belabor the point here. Olecranon bursitis, find it very helpful too in the clinic. It's so common. People come in with these olecranon bursa, my elbow hurts. Well, it's really a bursitis. But before you stick that needle in, is it worth it? Because you can cause some bleeding, cause infection, and not some discomfort. So some people, you don't really need to put a needle in there. They may have had chronic fibrosing disease in there for a long time, and you just find no fluid, but you'll find all tissue there, as opposed to a patient like this, where you see there's plenty of fluid, so you can guide your needle in and you can aspirate the fluid around, leave all this synovitis or whatever other tissue is still in there. And sometimes there'll be frank fluid, so it can be helpful and see if you drain everything out there. Nerve entrapment, it can also be helpful. Looking for carpal tunnel syndrome. So here you can see the nerve appearance versus the tendons, as we discussed before. But what can we do to determine if it's carpal tunnel syndrome? Because we can always find the median nerve. Well, we have some ways of measuring that. Instead of putting it through an EMG, we can measure it in cross section and then evaluate it in longitudinal. But the ultrasound measurement of median nerve size at the carpal tunnel inlet is where we're looking for. If it's larger, it means that it's being compressed at the carpal tunnel. So the cutoff, generally thought to be around 10, gives a sensitivity of 85%, specificity of 46%. The way I think about it, most rheumatologists think about it, is that some patients are larger than others. There's going to be a variation. If you have Shaquille O'Neal, who's huge, versus Tiny Tim, you're going to have different sizes of your median nerve at that site. So if it's less than 8 millimeters, we really think you're ruling out carpal tunnel syndrome. If it's greater than 12 millimeters, it's compressed and a bottleneck effect there. We think that's more likely carpal tunnel syndrome with the symptoms. And if it's in between, you may really need to still go for the EMG. But oftentimes we're able to make a diagnosis then and there and decide, do we inject, do we try other maneuvers, or do we look for other things? But I should say that ultrasound can be helpful for the nerve entrapment syndromes instead of EMG or nerve conduction syndromes for a couple other reasons. In the mild disease, it may be comparable sensitivity, so it could be helpful. But then also you can look for local anatomy in that wrist. You can find, are there deposits of amyloid? Is there synovitis from a rheumatoid picture? Is there crystal disease? There may be another reason for carpal tunnel syndrome that you can treat otherwise. And then also we can guide the injections into the carpal tunnel at the point of care right then and there. Transverse view is probably the best that way, and you don't hit the nerve and you get the medicine where it needs to be, as opposed to our blind injection, which we've done for decades. So this is really going through the list of sonopathology findings, the different diagnoses, how we really go from one to the other and back and forth, and really have it as a useful tool in rheumatology in the clinic. Aspirations are another key point here. There are some aspirations and injections we should not be doing without image guidance. We always used to have to send to radiology. Well, I think these are techniques that are very safe, and we should be able to do them in the clinic. Really, the hips and the popliteal cysts. First, with the hips, just showing you an image of some fluid there. You see where we put the probe, and there's some fluid. It's instead of the normal capsule coming really parallel to the bone, you have a enlarged capsule there. And so you stick your needle in, and you can get right into the area and aspirate the fluid, and it's drained, and your patients are doing much better. And we have much more beautiful images than that now. But the accuracy of using this for hip injections and aspirations is thought to be quite high. It's really not that painful to the patient. It's not like going into the other joints, and they really do well, and they come back for more a year later or 6 months later in terms of injecting and finding the right bony landmarks. For the posterior knee, I think it's very important just to show you what we do, because I do it for my patients. Not many rheumatologists, at least in NYU, are comfortable doing it. They don't really use ultrasound enough, so they still have to send out. But what I'm able to do, someone comes in with a popliteal cyst, I find the cyst as we show here on the transverse view, mark a popliteal artery with an X on the skin. and mark it down the skin. I know I want to go nowhere near that when I turn it around longitudinally. I don't want to hit the vessel, and I go find the cyst in longitudinal view. And then I can really do the aspiration and or injection, and it really doesn't take long to get there. And we can use sterile gel or whatever you need, but we really get in and aspirate. I've aspirated 100 cc's from a popliteal cyst in some patients. It's very helpful, and inject steroids there, and they're fine for a year. So I feel it really takes care of things within 10 to 15 minutes, and I think they're very satisfied. So I don't want to spend too much time here. I got some time for questions at the end, but just to briefly mention accuracy and outcome, I do think that these procedures are better when we use it for wrists, for shoulders, all the way through. I'm not going to go through detail, but just showing you that the palpation guided doesn't do as well, even in more experienced providers. So let's go through here. I'll end with one more vignette. I'll show you how ultrasound can be so important. Saw a patient, banker, lives in the suburbs north of the city, came in with 8 weeks of increasing MCP pain, swelling, difficulty making a fist, worse in the morning. Mom has rheumatoid, uncle has psoriasis. This has to be rheumatoid arthritis. Tender swollen joints on exam. Sed rate, CRP mildly elevated. Not the serologies were not. The rheumatoid factor, CCP, ANA really weren't diagnostic. So by ACR, American College of Rheumatology criteria, this is RA. We should start treating them. But I didn't feel comfortable. The labs weren't that great. It had been only 8 weeks. Wasn't enough for me to get really, really sure about it. I said, let's try some NSAIDs and come back. And why? Because when I put the probe down at that time, I wasn't convinced. I didn't see anything in his MCP joints on the dorsal or the volar side. And if this joint is so painful, you should see something in here. There's no effusion, no synovitis, no Doppler signal, no erosions. I did think there was a little cyst here. So while he met criteria by just some of what I mentioned, I decided to hold off. I said, NSAIDs, send some more labs, come back in a week. It was a snowstorm. He didn't come back for over a month, or a number of weeks, 2-3 weeks. All of a sudden, what do we see? We see all these nodules here, new erythematous nodules. So I did the ultrasound again, still nothing in the MCP joints, but these cysts are getting larger. So I think we have a different picture. So I don't know if any of you have any guesses, want to guess what it is? Anyone who's online right now? All right, so got more history. Of course, he cleans a fish tank at home. And of course, we had dermatology biopsies, lesions, and he came back as Mycobacterium marinum. Treated him with antibiotics. His hands got better. No disease-modifying drugs, no steroids, no arthritis medicines needed. So just showed that it can be helpful even when it's not arthritis. So in summary, point-of-care ultrasound is useful for our diagnosis, prognosis, and treatment. We need to know the key normal tissue first, and then we can delve into his rheumatologist, look for our pathology. The last piece of advice I give all my trainees is to follow the golden rule and be consistent in your positioning whatever you do, because over time you'll be a better rheumatologist and taking care of your patients. So I thank you for your attention. I hope to answer some questions you may have. I see there's a direct message to me, 1243 it's from BK. As for carpal tunnel, wouldn't regular assessment of both wrists be a better protocol for increasing specificity? And it's interesting. Some patients have bilateral carpal tunnel syndrome too, so you can't rule it out, but it's a good point. You can always, as with carpal tunnel, as with anything we do, right there in the bedside, we oftentimes do compare, and we use that split screen technique where we can compare right versus left, or two fingers in the same joint. But I think BK's question of doing both wrists is a good point. And oftentimes we will see, because if one is 11, not quite meeting that criteria, and their other carpal tunnel shows a median nerve size of only 8, I think you have a pretty good argument there that there's a carpal tunnel syndrome. So thank you for that question.
We have one question. Do you capture images, and are they available to other members of the healthcare team?
That's great. Thanks, Dr. Murphy. So I definitely capture images. For years, we had the old school system of just saving them, backing them up on the machine as well as my hard drive, because if we submitted images, we always wanted to be able to back them up if anyone in bills. But I do it a lot just for teaching or just to help them with the patients. But when I do a study, now the last 3 years, we've had it interface with our PAC system, and it's just an IT issue. The newer machines all have the capability, and I just have to export the images to PACS, and so any of the healthcare providers can see the images that we upload and label. Also for our studies, a lot of the studies we're doing it, and then it goes into the patient's electronic medical record. So that's been a very helpful tool.
Okay, thank you so much, Dr. Samuels. Really appreciate the lecture.
All right, have a great week, and hopefully meet some of you in person soon. Take care.
Thank you.